What we know about the pathophysiology and condition is very little. There are a lot of theories, none of which really are evidence and science-based. There's theory about glial cell involvement. There's theories about it being a dysfunction of the autonomic nervous system. I'm not sure that either of them are right or wrong. There is certainly, in my mind, a hormonal component to this because 80% of my patients are women. There's a genetic component because I have 18 families where more than one member has the disease and frequently in the same limb. But we really don't know enough, which is why we continue to do the research, try and raise money and find out some answers, because in order to make somebody better, you really need to go to the root cause. It's an interesting question in terms of differentiation in primary care, because primary care are the ones that see it first. In 1974, I had a doctor tell me, I was a medical student, he said, know what you don't know, and know somebody who knows what you don't know. And for 41 years, I've lived by that. If we can provide enough understanding to the primary care physicians to recognize this disease and recognize there are people who know what to do with it at its earliest stages, we've done a tremendous service to the patients afflicted with the disorder. So we're looking for patients that pain is disproportionate to the inciting event. We're looking for pain that doesn't match up to the diagnostic testing. We're looking for pain that's almost always burning. And we're looking for people who have other symptoms that are unexplained often, such as gastroenterologic or urinary or gynecologic, that just don't seem to be explained by conventional reasons that actually are a part and parcel of the RSD CRPS problem. Well, a lot of times in medicine, when we're looking to understand patients with unconventional symptoms, is to work backwards. Try and find out what is not wrong with the patient. Know by diagnostic testing what you're not dealing with. And sometimes, like Sherlock Holmes said, when you eliminate the impossible, whatever remains, however improbable, must be the answer. There's probably no better explanation than that. If you know what it is not, it becomes a lot easier to know what it is. And then when you get to that point where you are not really sure, then you have to do your homework and see if it plugs in. Get to the internet, do the research, look at the websites, look at the YouTube videos, and get that aha moment where you look and say, all right, now I know what it is. And even though I might not know what to do with it, I know somebody who does. When you talk about exacerbating factors, way at the top of the list is stress. Stress to me is the number one exacerbating factor, and number two is not even in the rearview mirror. But the rest of the group include infection, hormonal imbalances, thyroid, including thyroid dysfunction, infection, weather, climate changes. They'd probably be the biggest ones, but stress is such a tremendous, and even if not in CRPS, in all pain syndromes, when you get people under stress, and we're all under stress, and I try and tell patients you're defined by how you deal with the stress, and when that stress becomes the center focus of your life, it just gets into the core of you, and it becomes an exacerbating factor that just goes over the top. Thermography, to me, is the best, if not the only true diagnostic test for complex regional pain syndrome. We used to think bone scans, 3D bone scans were diagnostic, but there's so many of them that don't show the disease that I don't even do them anymore. I don't understand why you would inject a radioactive dye into somebody that has a problem and then radiate them. Thermography is non-invasive, it's non-contact. It measures the sympathetic function of the body. It measures the sensory portion of the nervous system as opposed to electrodiagnostic testing, which measures the motor portion of the system. So it really is a square peg in a square hole. It tells you everything you need to know without contact. It's simple to do. There's no downside to it. You can do it on anybody at any time because you're not invading the body in any fashion. And it gives you what I call objective medical evidence, meaning that when you have to justify your continued treatment to the payer, which is usually an insurance company, they're not going to take your word in all likelihood. They're going to look for something objective, and that objectivity comes in the form of a heat picture or thermogram, which is virtually impossible to fake, quote unquote. And so it is truly a picture of the sympathetic nervous system and what's causing the symptoms that the patient presents with. Treatment for CRPS always begins with mobilization, get somebody moving. And even if someone presents in my office in a wheelchair, there's still things they can do. There are still ways to move. So it's always movement first. Depending upon the stage at which I see someone, a lot of them come and have had this, that, and the next thing, but let's, for our purposes today, assume they've not. So we look at sympathetic blocks. We look at the use of different kinds of medication, not necessarily for pain, but things that will affect the NMDA portion of the brain, things that are anti-epileptics used off-label, things that are anti-inflammatories, muscle relaxants for muscle pain. So you sort of have to target the drug, if you're going to use drugs, to the symptom. I'm a big one for all natural, so I have everybody on probiotic because everybody that comes in has poor gut health between eating wrong, worrying, and antibiotics and all the things they've been through in their lives. So probiotics, fish oil, digestive enzymes, and multivitamins are the 4 keys in my office. Multivitamins for obvious reasons, because people don't eat well, and digestive enzymes because even people that eat reasonably well probably don't digest well. We look at balancing neurotransmitters and supplementing neurotransmitters with appropriate ones that are missing from the diagnostic regimen. We look at dietary adjustments because being gluten-free is a tremendous help in this disease. And if you can get people to be dairy and caffeine and sugar-free, all the better, but they kind of look at you cross-eyed when you ask them to lose all those things from their diet. And back to mobilization. Now, beyond that, sympathetic nerve blocks, physical therapy, occupational therapy, and then ketamine, which of course is the best therapy for refractory CRPS. And as we talked this morning, nobody's exactly sure why, but in my office, about 85% of people receiving ketamine have an improved quality of life, which either means they're doing more, they're taking less medicine, or they're doing more and taking less medicine, all of which is really good. And the quality of life is improved through the use of ketamine. Certainly, if I can make somebody better with a sympathetic block or simple physical therapy or a couple of non-opioid medications, great. And lastly is the psychological, getting people to understand when they walk in and say, my RSD has flared up, my answer is you don't want this disease. Give it to somebody you don't like. It's a disease like any other, and you need to have the attitude that you're not going to let that beat you. You're going to overcome the disease, and you're going to get on with your life. I think that they're part and parcel of the same thing. I think if you eliminate or reduce pain, you improve function. I think if I had to pick one, I still want people to be functional because there's that old saying, if you don't use it, you'll lose it, and people get frozen shoulders and knees that don't work from not using the body parts that they have to. But I think that you really want to do both, and you want to create an atmosphere where people understand that it's important to move, important to do all the things I just detailed. And if you do all those things, you're going to get better. And then people come in and say, well, if I can get 10% better, I'll be happy. And I look at them and I go, that's baloney, because if you get 10, you want 20, and 20 becomes 40. So you should want to be all better. And the goal, of course, is to get people all better. But absent that, our goal is to get people as better as we can, recognizing that even if they get to 70% tomorrow, that doesn't mean that 6 months or 2 years from now, they're not going to be 80 or 90%. I think the most important thing to leave the primary care physician is to recognize that when you get to a point that you've done all you can for a patient, whether it's CRPS or any other disease, there's somebody out there that can take it the next step. And it really is incumbent upon you as the family practitioner to say, okay, I've done all I can. I need to refer you to someone, not just in cases where somebody comes in with an obvious heart problem and you ship them out right away, but sometimes you enter into this with the great idea that you're going to make this person all better because maybe you think they have a simple problem. When simple becomes complex, it's okay to say, I don't know, and it's okay to say, I know somebody who does.